FLT3 mutations may be found in 30 to 35% of adult patients with acute myeloid leukemia. About 20 to 30% of the time, they will be the internal tandem duplication or ITD mutations. The other 5 to 10% of the time, they will be the tyrosine kinase domain substitutions and point mutations, so-called TKD mutations. Now, the prognostic significance of the FLT3 TKD is uncertain. However, there is much data about the prognostic significance of the internal tandem duplication. Most studies show that the presence of a FLT3 ITD does not affect the rate of complete remission with intensive chemotherapy. However, patients with AML with a FLT3 ITD mutation often have a higher rate of relapse and therefore a worse survival. In fact, even following allogeneic stem cell transplant, patients with a FLT3 ITD mutation are more likely to relapse than those who do not have one. Now, the effect of the FLT3 mutation can be affected or modulated by things like the allelic burden and other mutations as well.
So the FLT3 ITD and the IDH mutations are two major therapeutic mutations that in the last 5 years have become important in acute myeloid leukemia. These are quite different in the way that they impact the disease as well as their prognostic impact. The FLT3 ITD is usually associated with a highly proliferative, more aggressive disease with a high risk of relapse, and these patients usually need to go to allogeneic stem cell transplant, which now in most guidelines, including the NCCN and ELN guidelines, is considered a standard approach for FLT3 ITD mutated patients. And of course, there are a number of FLT3 inhibitors that have been developed which show good response rates either when combined with traditional chemotherapy or as single agents in the relapse. The IDH mutation, on the other hand, on its own is not an adverse mutation, and there have been a number of studies, some showing that there is a neutral impact with the IDH mutation, some showing that there is a favorable impact, and a few showing negative impact. But in general, most experts believe that the IDH is a neutral mutation. So traditionally, when we have IDH mutated patients, we would treat them with chemotherapy, and we would not necessarily take them to stem cell transplant, unlike FLT3 ITD mutations. The other thing is the IDH inhibitors, although they are called IDH inhibitors, like we call FLT3 inhibitors, don't really inhibit the IDH receptor. They actually inhibit a metabolic pathway that is driven by the IDH gene, which is a conversion of 2-hydroxy-beta-glutarate to a metabolic enzyme that results in differentiation. So the IDH inhibitors, when we use these, we actually see there is a promotion of differentiation of the leukemia cells, and it is this differentiation that allows the leukemia cells to get killed. And it's not a direct inhibition that we see with FLT3 ITD inhibitors that work directly on the receptors. The FLT3 ITD mutations in general are associated with a more proliferative disease, and preclinical studies have shown that patients who have a FLT3 ITD mutation on the blast tend to have a higher incidence of proliferation. Also, it seems to be difficult to eradicate the FLT3 ITD clone completely, and there have been some testing now done with digital deep sequencing, which is one of the most sensitive ways to look at any residual disease, and it has been shown that in many FLT3 ITD patients who achieve a traditional remission to chemotherapy, there is a low-level disease burden that can be identified with high sensitivity sequencing methods. So we think one of the main reasons that these people relapse is because they do have minimal residual disease, which can be picked up when you do very sensitive techniques for looking at FLT3. The other thing is FLT3 itself is a driver mutation. So if you do have any cells, even a few cells out of billions of cells that are remaining that bear the FLT3 ITD clone, this clone will over time, 6 months, a year, 2 years, result in relapse of the disease. So it is really important to try to eradicate every single FLT3 mutated cell, and that is not often possible with chemotherapy alone, and that's where we think the addition of FLT3 inhibitors or allogeneic stem cell transplant, or ideally both, may help us get rid of the disease 100%, preventing the relapses.
In general, there are two basic types of mutations that we distinguish in the pathogenesis of acute myeloid leukemia. Those that will block differentiation, the so-called type 2 mutations, and those that give a proliferative advantage to the cells, type 1 mutations. FLT3 mutations are examples of a type 1 mutation, a proliferative, and nucleophosmin, DNA methyltransferase 3A are examples of ones that will block differentiation. And so it appears that you need mutations in both classes to induce acute myeloid leukemia. Now, these mutations also interact in terms of prognosis. For example, the prognostic significance of the nucleophosmin mutation, FLT3 mutation, is most dramatic in patients with intermediate risk or normal karyotype AML. For example, in acute promyelocytic leukemia, high-risk patients have a higher incidence of FLT3 ITD mutation. However, this does not appear to affect the prognosis of these patients treated with all-trans retinoic acid, arsenic trioxide, either alone or in combination with chemotherapy. There are interactions of these mutations with each other in terms of prognosis. There was a large analysis of over 1,500 patient samples from the German study group. This was published by Eli Papa-Emmanuel about 2 years ago in the New England Journal of Medicine. Now, the three most common mutations that were found were FLT3 mutations, nucleophosmin, and DNA methyltransferase 3A. So she was able to look for interactions between these three mutations, and what she found was quite dramatic. The survival of patients with a FLT3 ITD mutation was the effect on survival was most profound in patients who had both mutated nucleophosmin and mutated DNA methyltransferase 3A. In the presence of wild-type alleles of both of them or either one alone, the effect of the FLT3 ITD was not as dramatic.